So let's look at the next topic, which is phacoemulsification in an eye with a shallow AC. In the morning, Dr. George spoke about lens extraction for angle closure glaucoma. We all know we are veering towards early lens extraction, but this is a factor that comes in the way because these eyes are not easy eyes for cataract surgeries. So there are various clinical situations where the AC is shallow. The extreme is nanophthalmos, microphthalmos, but the more common ones are anatomically shallow ACs with normal axial length, that is in relative anterior microphthalmos and angle closure glaucoma, and where you have an unstable lens, that is pseudo-exfoliation, and many times you have a hidden lens subluxation. The lens is the one which is making the AC shallows and certain hypermetropic eyes. So I'll restrict my presentation to this subset, not to the nanophthalmos, microphthalmos subset. So what is this relative anterior microphthalmos? Here the axial length is normal, but the anterior segment is shallow. The axial length is longer than 20.5, but the AC depth is less than 2.2 millimeters and the corneal diameter is shorter than 11 millimeters. So 6% of eyes fall into this category. Be wary of these. These are patients who don't even have glaucoma many times. So when you are planning your cataract surgery in the biometry, if you are getting your white to white and the AC depth, look at that and be wary and plan for surgery in these eyes. There is a high incidence of narrow angle glaucoma, corneal guttae, pseudo-exfoliation and small pupil, and the incidence of complications is very high in these eyes. So beforehand recognize and plan. Second, these eyes are frequently deep set. Smaller eyes tend to fit less orbital volume. They sit deeper in the orbit and make access challenging. So temporal approach can be advantageous. And also remember, the horizontal diameter of the cornea is relatively wider compared to the vertical diameter. And in small anterior segment, this small difference itself can make a difference in the access. I would prefer topical anesthesia with sedation because many of these patients have shallow orbits also. And if you give a significant amount of retrobulbar or peribulbar block, the eye becomes very tight and you can't even separate the lids. So it is a personal preference. You have to have adequate this thing. But I prefer topical anesthesia with sedation and if required a posterior subtenance later on. So the surgery should be meticulous starting from the incision because the iris is so close to the peripheral cornea. A proper two-step incision is very important. If your incision is not the proper two-step one, iris will prolapse. So that was the way to make the corneal incision. You can see here, though there is an attempt to make the two-step, the length of the tunnel is lesser. And when this happens in eyes with shallow AC, like you will see here, when you are doing hydrodissection, the iris just comes and plugs the wound. So once the iris starts coming into your openings, be it the side port or the main port, it keeps coming again and again. So the best thing is to prevent it, so make a proper two-step incision. The most important take-home message that I will give in this presentation of mine, extremely shallow anterior chambers, when there is no space, you need to create space. And how do you do that? By putting a pars plana port. So look at this eye. This eye has a very shallow anterior chamber. I put visco, it didn't form. Now I'm putting a highly retentive viscoelastic. You can see how it is coming out through the side ports. Now I am trying to do the rhexis, but I can't even make that needle vertical. It is sidewise because otherwise I will touch the endothelium. This is not a situation where I can do phaco correctly. So putting a pars plana port allows some amount of decreased pressure in the posterior vitreous cavity. And now you see when I form the AC, it forms so nicely, deeply. And now I can go in with the cystitome and do the capsulorhexis as comfortably as I would have done in an eye with a deep anterior chamber. So do not hesitate. I earlier used to call my VR colleagues to put this port, but now I do it myself. You can suture it at the end of the surgery with MIVS instruments being available. It is not such a big deal. So if there is less space, create space. The second important thing is use a highly retentive viscoelastic. So here your normal viscoelastic will not help. You have to use a highly retentive viscoelastic. I use Helon Hylein Z plus, or earlier it used to be Helon GV. So it acts almost like a third hand, and it keeps the anterior chamber formed and keeps the iris away from the wounds and the incisions. So the dispersive viscoelastic can be used as well to protect the endothelium in eyes which have borderline endothelial counts. And here the phaco parameters, it is individual, each surgeon's preference, but you would have a higher infusion height, a lower flow rate and lower suction levels to make the surgery safer in such eyes. So let's look at another problem during phaco which can be magnified in such people, which is the problem of surge. So when the flow is unobstructed, the intraocular pressure or the infusion maintains the high intraocular pressure and AC is formed. So once there is partial occlusion, the IOP starts raising, and once there is full occlusion, it reaches a plateau. And once the occlusion breaks, the outflow, the immediate outflow reduces the IOP and the AC collapses. And there is a time lag where the infusion recovers and the IOP comes back to the desired level. So this is the phenomenon that we call surge. Okay, so this surge can be problematic in eyes with shallow anterior chambers. So let's look at this video. This is an eye which had zonular weakness as well. You can see such an exaggerated surge which is happening. When the occlusion breaks, you can see that the anterior chamber just collapses. So this is something that we want to avoid. So in this, the active fluidics technology that we have with the Centurion machine is very helpful. With this technology, the surgeon selects the target intraocular pressure. This is a different target intraocular pressure. The patient eye level is selected, the irrigation factor and the IOP ramp are set. So throughout the procedure, the system works to maintain that target IOP by actively monitoring and responding to the changes in the vacuum pressure, irrigation pressure and the pump speed. So how does this happen? There is a constant measurement of the pressure in the irrigation line, aspiration line and the flow rate at 100 times per second. And based on that, there are motor control plates which squeeze and release the bag. So this maintains the target IOP, and this is maintained under flow and no flow conditions. So if you see this active fluidic system, if there is no active fluidics, this is the post-occlusion fluctuation which happens. With the active fluidics, this range becomes much lesser and the surgery becomes that much more easier. And this is combined with a infusion sleeve. So this is known as an intrepid infusion sleeve. So if you look at the cross section, there are these grooves like this. So this is not as easily compressed by the wound as it used to be without these intrepid infusion sleeves. So these two things increase the safety of the surgery, especially in these eyes with shallow anterior chambers. One more tip I would like to give. This is a surgery I'm doing with the Centurion. You can see even with the intrepid sleeve and the active fluidics, you can see when the occlusion breaks, there is still surge there. So here what happens is that, I will pause the video here. We all know that due to economic considerations, we can't use the sleeve, new sleeve for each patient. We re-sterilize the sleeves. It is a reality. So when you re-sterilize the sleeves, the sleeve loses its rigidity, and it is something which can get compressed by the wound. And also with this kind of an active fluidics and this intrepid sleeve, Alcon recommends that your incision be 2.4 and not 2.2. So if you find that the surge is happening even despite doing all this, if you just enlarge the wound a little bit, because some of these keratomes are also not very standard, they may be sub 2.2, just a little bit if you enlarge, not too much, just a wee bit, and then you go in with a phaco probe, this surge practically disappears with the active fluidics technology. So this is one practical thing, though the intrepid sleeve should work without this happening. You can see now there is hardly any surge. So in addition, upon your removing the instruments from the eye, stop and come to position 0 before you remove the phaco handpiece. If you remove with the infusion on, the iris will come in because your infusion goes under the iris and it pushes the iris into the wound. So go to position 0, then come out so that the iris doesn't prolapse. Unlike in other situations where flax has nothing extra to offer, in shallow AC definitely flax is something which is very advantageous. So you can see in this particular case, you can see the cross section as soon as it comes up. See, the AC is extremely shallow and the lens is so thick. So these are the typical angle closure shallow ACs that we encounter. So here the first step of the surgery, which is the capsulorhexis, can be done very safely, and the nucleofractus ensures that you are using less phaco power when you go in and do the phaco. So here again we have placed a pars plana 4 port because with such eyes, with these kind of, you can see that it's so difficult to make the side port. You have to be almost like, you know, it is touching the iris. So extremely shallow ACs, place a pars plana port. It makes your surgery that much more easier. Highly retentive viscoelastic, and now the AC is formed and you go about the surgery as usual. So there is a study by Dr. Vasavada's group which reiterates this. So when you randomized eyes with shallow ACs to flax and conventional phaco, the cumulative energy was lower in the flax group, the mean CCT was lower post-op, fewer eyes had inflammation, more inflammation, and the uncorrected distance visual acuity was also better with the flax group. So in this particular subset, flax is an advantage. And such eyes many times have non-dilating pupils, so you should use iris hooks. This is a combined AGB and cataract surgery. You can see that there's a corneal opacity and the AC is very shallow and the pupil is non-dilating. So in such eyes, you place the tube first and you can see separate the posterior synechiae. I tried to do it under air, but then had to use viscoelastic, and then you put the iris hooks, then wash out the viscoelastic and then stain the capsule. If you have the viscoelastic, it doesn't stain as well. And then the surgery is done as usual. And in such patients with shallow ACs, many times you will find that the zonules are weak. So in this particular case, after the cataract is removed, I find that the zonule is weak. So here I did place a CTR to make sure that the bag remains stable. And in this patient, when I'm putting the valve, again as I was telling in the discussion earlier, I place the valve in the sulcus. So I go behind the iris and place it behind the iris, and the bevel is facing backwards so that the endothelial decompensation does not occur. Zonule weakness is something that is very common in such eyes. Be alert, and if needed, use capsule hooks. So if in this paper which was published in the IJO, these eyes have more incidence of complications, and if you compare the normal AC depth eyes to the shallow AC depth eyes, the endothelial cell loss is more, the number of complications are more, as you can see in these tables. So one should be alert and should be having an operative plan to tackle all of these things when you are going in to do a phaco in an eye with a shallow anterior chamber. So those are just few tips. I would like to acknowledge the help of my fellow in collecting the videos and my OT staff for editing the videos for me. Thank you.
Thank you, madam. Wonderful practical tips and wonderful videos. Now, a few questions, like in a deep set eye, would you like to do a temporal side incision or a superior?
Temporal incision.
Okay, because most of your incisions appear to be...
I prefer a superior incision usually,
no,
but
fine,
definitely I remember and try to make it temporal.
And regarding topical versus local anesthesia, apart from subtenance, do you do subtenance?
I do subtenance, but I prefer topical with sedation, because we have the luxury of having an anesthetist throughout. So topical with sedation is something that I prefer, and if I need to supplement, posterior subtenance.
Okay, ma'am.
Just one comment I have. I think one of the most important message here is this pars plana
Port.
The port, but it's not easy for all of you to have access. A simple method is just use a 30 gauge needle on a 22 cc syringe. Just stick it into the pars plana, direct it towards the optic nerve. Your needle is only about 12 millimeters. So there's no harm. You will never hit the optic nerve. Go in and aspirate, and it will only aspirate the fluid, the misdirected fluid. I think most of these patients have misdirected fluid, which is why it's so difficult to form the anterior chamber. Just go in with the needle, aspirate, and then rest of the surgery is a cakewalk, really.
And this port, you can put a plug once you have formed the AC, so that the vitreous doesn't keep on coming into the port. And at the end of the surgery, though this is an MIVS port, I strongly recommend you should suture the port. So that, that is complete, because I usually make them myself, so I invariably suture it, because the MIVS, the VR surgeons make it in a tangential way, so that it is valvular and it remains, it doesn't need a suture. But for these cases, I always suture the port.